see I think still the presenter view with the slides at the bottom.
All right. How about now?
Yep, that looks great.
Great.
Okay, let's go ahead and get started.
Okay. Good morning. Welcome, everybody, to the May ACC Updates in TB Treatment and Prevention for People with HIV. I am very happy to introduce Dr. Adrienne Shapiro, who is an assistant professor in the Department of Global Health, the Department of Medicine, and adjunct in epidemiology, as well as a recently named fellow of IDSA. Congratulations for that, Adrienne. So thank you so much for being here with us and talking to us about TB treatment and prevention today.
Thanks so much, Julie, and it is great to be here. I have included this updates icon because I gave this talk last year, almost exactly a year ago, and there are some things that are the same and some key updates, which I've tried to highlight throughout with the icon. So if things look familiar but a little bit different, I've tried to indicate why that might be. These are my disclosures, and so the objectives for the talk today will be to understand the approach and interpretation of screening for TB infection in people with HIV, to also describe key drug interactions between antiretroviral therapy, including long-acting ART agents used for treatment and prevention of HIV, with the drugs that are used for treatment and prevention of TB, in order to design effective treatment combinations for patients, and some notes on timing considerations and adjunctive therapies for treatment of TB in people with HIV in order to optimize patient outcomes. There are a lot of acronyms that I will be using throughout the talk, so I've included this slide as a reference, and hopefully you can download the slides and go back to it if things get a little bit confusing with the acronyms and abbreviations. But all of the acronyms are in service of talking about TB, TB infection, which I'm going to use the term Mycobacterium tuberculosis infection as an evolving replacement term for the term latent TB infection, or LTBI. Sort of recognizing it's our different understanding, or our evolving understanding of TB as a spectrum from infection to disease, and then abbreviations for drugs, treatments for both TB and HIV. So the fundamental principles of screening and treating HIV and TB are how I'm going to start the discussion. So fundamentally, and this is true, this is promoted in WHO international guidelines. This is also promoted in the US DHHS guidelines. All people with HIV should be screened for TB. And all people with HIV should be given antiretroviral therapy. So within these two fundamental principles, what do you do once you screen someone for TB? Well, if somebody with HIV has TB disease, they should start TB treatment immediately. And if after screening someone for TB, they do not have TB disease, then the next step depends on the incidence setting for TB where you are. In a high TB incidence setting, there's no further testing that needs to be done. TB preventive therapy can be started immediately. In low TB incidence settings like the US, where most of us are working, the next step would be, after you've excluded TB disease, to test for TB infection, and then to provide TB preventive therapy if the TB infection test is positive. So this is an IGRA, like a quantiferon test, or a skin test. If somebody is reactive with one of these tests, then and they do not have TB disease, then they should receive TB preventive therapy. So when should you repeat screening for MTB infection? So say you have a new patient entering care, you screen them for TB infection, it is negative. Should this person be screened for TB infection again, and at what cadence? So if you've screened someone for TB infection and they are positive, then you treat them with TB preventive therapy, but then that test is always going to be positive. So they should never be screened again for TB infection, at least not until we have better tests that can distinguish reinfections from prior infections. So that person should be screened for new symptoms or new signs of TB disease, but this is the tests for TB infection are one and done. So once it's positive, it's always going to be positive. If the person with HIV has negative testing for TB infection at entry to care, there are essentially two conditions where they should be screened again. So if they have a new potential exposure to TB and a new possibility of acquiring TB infection, they should be rescreened because that's another opportunity to prevent TB. The second state is if the individual enters care and has TB infection screening while they are immunosuppressed, for example, a CD4 count of less than 200, then there's a risk of a false negative quantiferon, a false negative IGRA, or a false negative TST, since all of those testing depend on cell-mediated immunity, CD4, essentially CD4, functioning CD4 counts. And so if somebody is immunosuppressed at the time of initial testing for TB infection, they should be rescreened for TB infection when they have reconstituted immunity with a CD4 above 200-ish. There's no hard and fast rule for that, but that's the guideline that I use to ensure that TB infection is not missed. So again, the key principles are screen people with HIV for TB. All people with HIV should be treated with antiretroviral therapy, and the goal of antiretroviral therapy is virologic suppression. If somebody is taking ART at the time that TB or TB infection is diagnosed, they should not stop ART. The ART may need to switch depending on what options are available for TB treatment or TB preventive therapy, but there's no recommendation to stop taking ART. And we'll talk a little bit later about if someone comes in and they are not on ART, they're not on TB treatment, how to time the initiation of ART with TB treatment. So a key challenge for ART and TB treatment is that rifampin or rifampicin and rifapentine, which are two drugs that are core drugs for both treatment and prevention of TB. These drugs are potent inducers of CYP450. This causes a drug-drug interaction with many antiretrovirals, and the effect of that interaction is to decrease the levels of ART. And this puts patients at risk for virologic rebound, or for people on PrEP, it leads to decreased levels of protection. So it's important to have shared decision-making with patients to determine whether switching ART to optimize TB or TPT is preferred, or to choose a TPT regimen to meet the existing ART if ART options are limited. And I like to think of the interactions between TB treatment, TB preventive therapy, and ART as similar to a blood donation scenario. So we have universal donors and universal recipients. We have universal TPT. So this is TB preventive therapy that can be given with any regimen of ART. And this is daily isoniazid for 6 or 9 months. There is a universal ART regimen, which is compatible with all forms of TB treatment and TB preventive therapy. And this is a triplet or TDF-FTC efavirenz. And then extending this metaphor to PrEP, there's a universal PrEP, which is compatible with all forms of TB treatment and TB preventive therapy, which is TDF-FTC. But all other TPT options and TB treatment are likely to require some ART adjustment. So looking at these options for universal treatment, universal prevention, TDF-FTC efavirenz is appealing because it has no negative drug-drug interactions, but this is no longer first-line therapy in the US for ART or anywhere else in the world. The standard first-line ART in most of the world is TDF-3TC dolutegravir or TLD, and this is compatible with many forms of TB preventive therapy, but with TB treatment, this regimen needs to be slightly modified by giving a second dose of dolutegravir as a single drug, along with daily TB treatment for as long as rifampin is a component of TB treatment. And so this alters the convenience of a one pill once a day regimen by having a second pill that is given of a single drug. So it challenges both the convenience and the safety of a single pill combination regimen by having free dolutegravir in the wild. The global second line uh, ART of lopinavir, ritonavir, boosted lopinavir is compatible with TB treatment with daily rifampin, but again, there needs to be a doubling of the dose of lopinavir, ritonavir, which causes increased side effects. Previously, and still to a certain extent, there's been a lot of caution about giving TAF with rifampin. But some very exciting new data has been emerging over the last few years, pharmacokinetic data, and now new treatment data that indicates that if you double the dose of TAF, actually, if you give TAF BID instead of daily, the levels of TAF or the levels of tenofovir intracellularly still achieve the same protective levels as they would in the absence of rifampin. So this is an update from previous that has not yet changed guidelines, but I anticipate that in the next few months to a year, we will be seeing more options for giving TAF including ART with daily rifampin for either TB treatment or TB prevention. So a warning, there's going to be a lot of ART alphabet soup ahead, and I've also tried to use color coding indications for when there is an absolute contraindication for giving an ART medication with daily rifampin. Orange or yellow is sort of a relative contraindication where dose adjustments can be possible. And then green is fully okay to give treatment concurrently with the ART and the TB treatment. So from our guidelines in the US for first-line ART is an INSTI and 2 NRTIs. And this is often given as Big-TAF-FTC or Biktarvy, or dolutegravir plus TAF or TDF plus FTC or 3TC. And the three integrase inhibitors that are the main basis of first-line ART are bictegravir, dolutegravir, which both have relative contraindications, as in they do require adjustments to be given with rifampin because rifampin will lower their levels, and then cabotegravir as a component of long-acting ART. Cabotegravir cannot be given with daily RIF. Levels are decreased below a level that's therapeutic, and there are no current recommendations for dose adjusting CAB to be given safely with daily rifampin. Dolutegravir plus tenofovir or FTC or 3TC can be given with daily RIF if the dolutegravir is dose adjusted to be given BID. And then a recent clinical trial that was published just a month ago found that giving Biktarvy or Big-TAF-FTC BID along with daily rifampin-based TB treatment was safe and efficacious and achieved similar intracellular tenofovir levels compared to daily TAF without RIF. So this is probably going to lead to a change in guidelines soon, and this gives greater flexibility in allowing people to stay taking a single pill combination regimen for ART. It does need to be given twice a day instead of daily when given alongside TB treatment, but in the last few years, patients on Biktarvy who have needed to take TB treatment have had to switch. There have really essentially been no options for giving TB treatment along with Biktarvy. So this is exciting to provide new potential to allow people to continue their existing ART. For first-line treatment, 2 INSTIs plus an NRTI, dolutegravir 3TC is as the recommended first-line regimen. And again, dolutegravir can be given with TB treatment, but would need dose adjustment. The other regimens with darunavir, COBI, or darunavir, ritonavir with TAF and FTC 3TC, This is first line if there's a history of receiving long-acting PrEP, and these PIs are contraindicated with RIF. So these are not treatment options for someone who needs TB treatment. And then for alternate and second line ART, all of the other protease inhibitors besides busulfan are contraindicated. Dose adjustments for busulfan. There's a new drug on now available and recommended as alternate ART. So islatravir is an NRTTI. The drug itself does not interact with RIF. However, islatravir is only available in combination with doravirine, and RIF does decrease doravirine levels below therapeutic levels. So this combination ART cannot be given with TB treatment, with daily rifampin treatment. With NNRTIs, efavirenz is the only medication that does not have interactions with RIF. Others are contraindicated, and our universal ART does not require any dose adjustments with RIF. Long-acting ART formulations used for either treatment or prevention of HIV have some interesting and a little bit conflicting or non-intuitive drug interactions with TB drugs. So drugs used for ART, the long-acting medications, Cabenuva, cabinilpivirine, and lenacapavir, when used for ART, all are contraindicated with daily RIF. These and this is the non-intuitive part is that when lenacapavir is used as PrEP, there actually are recommendations for providing supplemental doses, both of the injectable and of the oral dose, that can be given when starting daily rifampin, that allow lenacapavir to be given compatibly with TB treatment or TB preventive therapy. And so the package insert for Len provides guidance for providing supplemental doses of Len when either moderate or strong inducers of CYP450 are given. And this is particularly significant in a global context where lenacapavir is being used for PrEP, and there are high rates of TB, both infection and disease requiring treatment, and it would be incredibly problematic if a long-acting 6-monthly injectable form of PrEP became instantly inaccessible when somebody needed TB treatment. So the PK studies were done, the dosing recommendations were made to provide supplemental dosing. So this is an update from last year, both with having Len as PrEP and to have Len as compatible with TB treatment and TB preventive therapy. So even though it's the same drug, the studies were not done with lenacapavir for treatment to identify whether supplemental dosing could overcome the interaction effects of rifampin. So for now, the recommendations are still to continue or to find an alternate treatment, an alternate ART, if TB treatment is required. So again, the summary for all of these is for TB treatment, there may need to be a switch from long-acting ART to daily oral ART. So for treatment, long-acting injectables will need to be replaced with a daily oral ART regimen. PrEP may be able to be continued, but PrEP may, for CAB-LA as PrEP, would need to be switched to a daily oral PrEP as coverage during TB treatment. For TB preventive therapy, this is another opportunity for discussing shared decision-making and discussing risk benefits and preferences with the patient. So I've created this table as essentially a reference guide for myself for how to think about TB treatment and ART. So thinking about the different options for TB treatment and which ART regimens are compatible with those TB treatment regimens. So the standard TB treatment regimen of 2 months of 4 drugs, isoniazid, rifampin, pyrazinamide, and ethambutol, followed by 4 months of isoniazid and rifampin. So a total of 6 months of daily medication. This has three definitely and guideline-driven compatible regimens. So TDF-FTC and dolutegravir with the dolutegravir given BID, or 3-TC dolutegravir, again with the dolutegravir given BID, or TDF-FTC efavirenz. So all of these, even as of last year, were the available ART. This year, I've included in bolded bright red letters the Biktarvy BID, BICTAF FTC, with the guidance that this is not yet, again, not yet guideline recommended, but there is evidence that this is safe, effective for both maintenance of viral suppression and safe in terms of adverse effects. So this is an update for last year, and similarly, the 4-month daily regimen for TB treatment that was approved a few years ago and entered into guidelines, formal guidelines last year, although there have been CDC recommendations for HPMZ, which is 2 months of isoniazid, rifapentine, moxifloxacin, and pyrazinamide, followed by 2 months, followed by 2 months of 4 drugs, followed by 2 months of 3 drugs. This is a 4-month daily regimen, a short TB treatment regimen. This can be given with the same TDF-FTC BID dolutegravir or 3-TC BID dolutegravir or TDF-FTC efavirenz. The third TB treatment regimen I've put in the chart this year as an update is the 6-month daily TB treatment regimen, but using rifabutin instead of rifampin. And rifabutin has fewer drug-drug interactions with ART, has different properties of being a CYP450 inducer, and so there is increasing clinical evidence and clinical practice evidence that allows sort of previously incompatible regimens to be given with this TB treatment regimen. Rifabutin is relatively harder to acquire. There are often shortages of it. It is often reserved for people who really require either an existing form of ART if there are adherence concerns in particular, and someone really needs to stay on a 1 pill once a day regimen. This can be an option. We are learning more, and hopefully we'll have more accumulated evidence to demonstrate safety and efficacy of this. But replacing rifampin with rifabutin allows for daily TDF-FTC dolutegravir, and again, increasing evidence that daily Biktarvy would be compatible with this TB treatment. So this gets around the need to have a second dose of dolutegravir solo or a BID Biktarvy regimen. We have a few more options when it comes to TB preventive therapy and ART. And again, I'll point to the universal TB preventive therapy, which is 6 months of daily isoniazid, which requires no change to ART. All ART are compatible with this. Isoniazid is at the bottom of the chart for TB preventive therapy because it is both the longest regimen, the least likely for people to complete it, and it also has the highest toxicity, specifically hepatotoxicity. And so in the last 5 or 6 years, isoniazid has moved from the leading recommendation for TB preventive therapy for people with HIV to now the least preferred. The most preferred regimen, if possible, for TB preventive therapy is 3HP, which is the second row, which is 3 months of weekly isoniazid and rifapentine. And this has the most unadjusted options for ART that it is compatible with. So TDF-FTC dolutegravir or 3-TC dolutegravir or TDF-FTC efavirenz. All other TPT regimens that contain a rifamycin, so either rifampin or rifapentine, require some adjustment of ART outside of the TDF-FTC efavirenz. So you can see that is highlighted as unadjusted and unchanged throughout. That's the universal ART. The advantage of giving TB preventive therapy that contains either rifampin or rifapentine is that all of these regimens are much shorter than the 6 to 9 months of isoniazid. And shorter regimens mean better adherence, greater likelihood of completion, and in head-to-head trials, these regimens also have fewer side effects in terms of hepatotoxicity in particular. So the other TPT options are, again, much shorter. So the 4 months of daily rifampin is a single drug TPT regimen. However, with a daily rifampin, there are going to need to be dose adjustments, and this is often not recommended because of that. The 3 months of daily isoniazid and rifampin combination also shorter than the 4 month of daily RIF, but also has the similar daily interactions. So really the kind of best options for most people living with HIV on ART are either the 3 month of weekly isoniazid rifapentine 3-HP, or increasingly being used as an alternate regimen is 1-HP. So 1 month of daily isoniazid and rifapentine can be given as TB preventive therapy to people with HIV on ART. And this, because it has a daily rifamycin, does require dose adjustment with BID dolutegravir in either TDF-FTC dolutegravir or 3-TC dolutegravir. Okay, so we've gone through a lot of alphabet soup with both ART and TB treatment and TPT. What are some of the considerations for switching ART? So switching ART, if you have a patient who has TB disease, needs TB treatment, chances are pretty high that you'll need to switch ART. And switching ART is a very vulnerable time for loss of virologic control. And this is a time to really be thinking about how can the patient be supported to maintain good adherence with the switch? How complicated is the switch? There are, as we're still moving into a period of time where we are not recommending prescribing TAF-containing regimens along with TB treatment, thinking about switching TAF-FTC to TDF-FTC can often begin an invisible switch. If this is being given as a separate, as a distinct medication, the switch will probably be invisible to the patient, will probably be pretty straightforward. Different if it's given in a combination pill like Biktarvy, but if it's dolutegravir, TAF-FTC, that switch to dolutegravir, TDF-FTC is pretty straightforward. One pill daily, such as Biktarvy, is still by guidelines going to be recommended to be switched to at least one pill BID and one pill daily. That's a little bit more complicated. Is there a one pill option? For some people for whom a single tablet daily is a critical component of their ART adherence and maintenance of suppression, this is a time when considering second-line ART, like TDF-FTC efavirenz, might be the most useful for this particular patient. And bearing in mind that the ART is usually not the main driver of pill burden for patients who are taking ART and TB treatment or TB preventive therapy. So we are in a relative disadvantaged position in the US where we do not have fixed dose combination tablets and I'm just going to go back to remind us that these TB treatment regimens contain multiple drugs. Most of these are given as single drugs, not in combination. And so the handful of pills that someone is going to be taking for most of their TB treatment is really going to be driven by the TB treatment and possibly adjunctive pyridoxine given to prevent side effects from isoniazid. Their ART is a relatively minor contribution to that pill burden, but still for some people, the idea of taking one pill once a day of ART is really important for their HIV management. And so this is part of the discussion to be had with a patient. A second consideration for for changing ART in order to safely give TB treatment alongside is that the way the pharmacokinetics of rifampin work and the way it induces the liver enzyme is that it takes about 2 weeks to ramp up and then lasts for 2 weeks. The P450 is induced still at therapeutically meaningful levels for 2 weeks after the rifampin is stopped. And so patients need to be counseled that they need to be taking their extra dose of dolutegravir, for example, for 2 weeks after the TB treatment is finished until the enzymes are completely reset and back to baseline. And that 2-week tail can be hard to explain, can be hard to understand. And so just thinking about how much how much tolerance a patient or a provider will have for that kind of careful counseling may affect treatment decisions. If a patient is highly treatment experienced or if they are not virologically suppressed, they may really have very limited ART options. INSTI-containing regimens are the most potent at suppressing viral load, and so changing ART really may not be an option for someone who is not suppressed or has a lot of resistance. And this is a case where potentially working with a TB clinic or a TB expert to craft safe regimens. And I'll highlight that there is a Curry Center based in San Francisco has a warm line for discussing these in King County. The King County TB clinic, our clinicians are excellent at discussing compatible regimens and working through drug-drug interactions. Our pharmacists are outstanding. But for highly treatment experienced patients on salvage regimens, adding in rifampin, which is entirely necessary for TB treatment, can be a challenge. This may be a time when using rifabutin instead of rifampin is helpful to accommodate some of these issues, along with careful lab monitoring. Really understanding patient priorities are particularly important, and even more important when discussing TB preventive therapy. So although we have the options of short, 1 month, ranging from 1 month to 4 months, 4-month regimens, for TPT. TPT is temporary, ART is for life. And so patients may really feel that they want the ART regimen that is most compatible with their preferences. And so that may mean choosing a TPT regimen to accommodate the ART preference if that is the priority. And I will end this section with just one note about my practice. So I have a lot of patients in my practice who are coming from low and middle income countries. They're coming in on TLD, and they are coming from high TB incident settings and test positive for TB infection with an IGRA. So these are patients who are on TLD. They need TB preventive therapy. And my practice is for sort of generally off the bat, if somebody is not needing TPT, I typically will start individuals on a 1 pill once a day regimen for convenience. But for this group of patients, I tend to start TDF-FTC and dolutegravir while I'm waiting for their quantiferon result to come back. And that's because I will only need to change the dolutegravir dosing potentially or not at all. So I can make one switch. If I start them on TDF-FTC dolutegravir, then if they're confirmed negative, they can either continue on that, which is essentially equivalent to the TLD that they were on before, or we can discuss switching to a single pill regimen. Or if they're IGRA positive, then I can give them 3-HP, which is fully compatible with TDF-FTC dolutegravir without needing an extra dose of dolutegravir. And then at the end of the TB preventive therapy course, can discuss whether they would prefer a single pill regimen or if they're happy to stay where they are. Moving into discussion of TPT and PrEP, so preventive therapy for TB and prevention for HIV. Again, we have the same options for TPT as before, the 4 rifamycin-containing shorter regimens and the two longer isoniazid regimens. Again, isoniazid needs no adjustment with any form of PrEP. The compatible PrEP, current sort of guideline advised compatible PrEP with the different TB preventive therapy regimens are TDF-FTC, the universal PrEP, and then we do have the option of lenacapavir with supplemental dosing for each of the different regimens. So for the TPT regimens that contain rifampin, which is a strong inducer, these patients could, if they're receiving len for PrEP, they could continue len and get the strong inducer supplemental dose. For the rifapentine containing regimens, so 3-HP, which is weekly, or 1-HP, which is daily. If they're already receiving len for PrEP, they could continue with len, but get a moderate inducer supplemental dose at the time that the TPT is started. So at the time that RIF or rifapentine is started as part of the TB preventive therapy. So we had discussed at the beginning that if somebody is on ART at the time that TB is diagnosed, they should stay on ART and start TB treatment immediately. But there has long been a question of when to start ART in someone with HIV who has TB. So if somebody enters care and at entry into care, they are found to have HIV and TB, there are a lot of considerations to balance in terms of how and what to start. We know they need ART, they need to regain immune function. The goal of initiating ART is to achieve rapid virologic suppression and reduce risk of reduce risk of HIV-associated comorbidities to allow the immune system to reconstitute. TB treatment is less successful in people with HIV who are immune suppressed because there's a large component of TB treatment that relies on the immune system to do its job in part of clearing out the TB. So there's been this tension of should we start ART early to give people these maximum benefits. So starting ART early, which means within 2 weeks of starting TB treatment. Or should we wait up to 8 weeks, for example, before starting ART to allow the patient to acclimate to the TB treatment, which is a lot of medication, to reduce pill burden, to allow assessment of any adverse effects, to make it clear that if there are adverse effects, these are from TB drugs and not from the ART. So the advantages of starting early is that you, or I guess the challenges of starting early is that you have a higher risk of immune reconstitution syndrome, have a higher risk of drug-drug interactions with multiple TB and ART drugs, drug toxicities unrelated to drug-drug interactions, and pill burden, big handfuls of pills. However, the consequences of starting late, waiting to start ART until TB treatment has been on board for longer, is that you have a higher risk of having persistent immunosuppression, prolonged risk of non-TB comorbidity and mortality, and a risk of a lower likelihood of TB cure with TB medication alone in the absence of ART. So there have been a number of randomized control trials done specifically to address this question, where people with TB and HIV not on ART are randomized to an early versus a late start. And the guidelines have settled out on the recommendation that for people with a CD4 count less than 50, TB treatment should be started immediately, and then ART should be started within 2 weeks. So an early start, essentially start ART as soon as possible, and definitely within the first 2 weeks of starting TB treatment. And that's because there is a clear mortality benefit for an early start when immunosuppression is highly advanced, CD4 count less than 50. For a CD4 count greater than 50, there is no mortality benefit to early ART. So there's a little bit more room, there's a little bit more of a cushion to work out some of the drug-drug interactions, some of the toxicities. So the recommendation for a CD4 count of greater than 50 is, again, to start TB treatment immediately. That's consistent across all people with TB should have TB treatment started immediately. But because there's no mortality benefit to ART may be delayed for up to 8 weeks. But again, stressing that this doesn't mean ART has to wait for 8 weeks. It just means that there's not a demonstrated benefit to starting immediately, so there's more room. In 2021, the WHO, while recognizing the mortality benefit for CD4 count less than 50, also recognized that there can be a logistical and sort of patient flow benefit for starting ART early, in line with the recognition that, in the ART guidelines, there is decreased mortality for ART with an early start. And so globally, recommendations are to start ART within a week and ideally on the day of entry into care. And so the recommendations globally have essentially moved to the idea that ART should be started as soon as possible. And again, this is compatible with the idea that even for a CD4 count of greater than 50, just because there's not a mortality benefit from a TB perspective to starting early ART immediately, we've seen over the course of hundreds of thousands of patients that there is a benefit to starting the ART, like not delaying ART care for any reason. And so that again gives more flexibility and more encouragement for starting the ART early. Of course, this is always going to be a patient-by-patient decision. If someone is having a lot of side effects with TB treatment, if they have other comorbidities, if things are very unstable, if they have illness requiring hospitalization, again, there's much more room to start the TB treatment, get things settled out, and then wait to start the ART. But if this is all in an outpatient setting, it may actually be most convenient to start both at the same time. So a few other considerations for treating TB in people living with HIV. We'd mentioned IRIS as a concern about starting ART early. So immune reconstitution syndrome can occur when ART is started early while there's still a high TB bacterial load in the body. And IRIS can be very problematic. It may require treatment with high-dose steroids to decrease the inflammation. And in 2018, the PREDART trial was done that showed a reduction in IRIS and a reduction in the total amount of steroids required for patients if empiric steroids were started at the time of TB treatment and ART for people living with HIV with a CD4 count less than 100. So for highly immunosuppressed patients, starting low-dose empiric steroids at the time of starting TB treatment and ART minimizes risk of IRIS and minimizes total steroid dose. And some of the restrictions for which patients would be eligible for this treatment, adjunctive treatment, would be people whose TB is known to not be resistant to rifampin, and also to not have other contraindications to steroids, such as having KS or Hep B. There has been a lot of interest in trying to increase the success of TB treatment and potentially even shorten TB treatment by increasing the dose of rifampin given. There's some early evidence that suggested that higher dose rifampin may improve survival. So the RAFA trial, which was reported in an abstract in 2016, showed a reduction in mortality with high-dose RIF. Part of the motivation for this is that in PK studies of rifampin, studies were finding that standard doses of rifampin did not achieve high levels systemically and didn't achieve even what are considered minimally therapeutic levels in certain compartments, such as in the brain. And so there is a lot of interest in trying to give high dose rifampin for TB meningitis in particular, which is globally most likely to affect people living with HIV. But a series of studies that have been either published or presented in the last few years have not held up this initial signal that higher dose RIF would be beneficial. So the new STRAT trial was a study giving intensified TB treatment with higher dose rifampin to people with HIV and TB who are hospitalized. And that trial was stopped early due to a signal that there may actually be worse outcomes in people receiving the intervention, which was high dose rifampin and levofloxacin. The Datura trial, which also compared intensified TB treatment and steroids to standard TB treatment for people with HIV and immunosuppression, again, showed no mortality benefit for high dose TB treatment, high dose RIF. And then late last year in 2025, the Harvest trial was published that showed that for TB meningitis, there is no mortality benefit to giving higher dose rifampin, and that in some patients who received higher dose rifampin, there were more adverse events. So I still don't think that the story is completely settled on how to improve TB treatment outcomes with dose adjustments for RIF or intensified TB treatment, but there's certainly not enough evidence accumulated as of now to suggest that RIF, high dose RIF is beneficial for all people with HIV and advanced immunosuppression, certainly not for all people with HIV. There may still be a subset of people who may benefit from high dose RIF, but that group has not yet been identified. So I'd say keep an eye on this space, and hopefully in the next iteration of this talk, I'll have another update in that space. And then just one other trial I like to mention. This is an implementation trial, which essentially provided TB treatment and ART initiation on the same day in an outpatient setting, and showed that immediate ART, if TB symptoms are mild and the patient is otherwise well, is as effective, and no concerns about safety or adverse events in outpatients. So I'm going to end here with listing some of the references for these studies, including both WHO and DHHS guidelines, and the publications that have supported the updates in particular. And thank you all for your attention. Appreciate it.
Thank you, Adrienne, so much for that talk. I don't have any questions just yet, but they may take a bit to come in. Please put your questions in the Q&A box for Adrienne. And Victor just put in a link to the evaluation, and you can see, hopefully, Adrienne, you're getting some applause. So while we're waiting for that, well, I just want to give people a minute. I know they're coming. Lots of hearts. I guess I'm curious, as you were putting together this talk and that you went over a lot of updates and a lot of really rich information, what do you hope will be some of the one or two updated points that clinicians will carry away from this?
Yeah, so I think for me, what I'm hoping to make practice changes about in the near future are the really exciting evidence about being able to give Biktarvy BID along with TB treatment. I think that's really going to simplify treatment decision making, simplify ART for patients a lot. And given that the vast majority of my patients are on Biktarvy as their ART, although we don't have a ton of TB, Washington has more TB than most states, but compared to other settings where I've worked, South Africa, Kenya, relatively less. The number of times I have to make these kinds of treatment decisions are small. the place where I do have more considerations are with TB preventive therapy, which I prescribe frequently and often. And so I am most excited about the increasing clinical experience with the 1 month regimen for TB preventive therapy, the 1 HP that can be given daily for 1 month. And I just think that we are doing our patients a disservice, we're doing our community a disservice by, as a whole, as a practice, not doing as much screening and treatment of TB infection. And the more options that we have to make these treatment regimens shorter, easier to take, fewer side effects, the better. So we're still challenged by the fact that there are rifapentine shortages, which makes rifapentine less available to our patients. It's also more expensive, and insurance, there are still challenges with it. But overall, my two big trend takeaways are shorter and simpler treatment for TB and TB prevention.
Great. Those are excellent takeaways. And we do have a few questions now. So first one from Chase Cannon. Have you had success transitioning people to efavirenz in the US? I think most people with HIV either don't know about it or took it long ago and remember side effects.
Yeah, so that's a great question. Been, I think there have been one or two patients where I have ended up putting them on TDF-FTC efavirenz. Um, in general, I have not done that. There have either been TPT or TB treatment regimens that have been compatible or enough with simple modifications. I, I actually have a number of patients who fondly remember a triplet, and so I've patients who have requested to go back on a triplet if there's been some talk about changing their medications. So I think your experience where people are remembering side effects or people haven't heard of it is certainly going to be increasingly the trend, certainly the having heard of it. But we can still get it for now. And I think it remains an option if there's a lot of complexity involved. It can help simplify things. But I mean, the side effects are real, the neurotoxicities are real, and something that needs to be taken into consideration.
Great. Next question is from Jimmy Ma. Are there thoughts on Len for HIV dosing using Yes2Go data while on TB therapy?
Yeah, so I think that it would be certainly rational to extend the data about supplemental dosing to be able to provide that when Len is being given as treatment. And I the package insert hasn't been changed because the studies haven't been done. I think there probably aren't enough people on Len who would need TB treatment. Enough people on Len for ART who would need TB treatment to ever do that study. So I think for me as a clinician, I would be comfortable providing the supplemental dosing recommended for Yes2Go to somebody receiving Sunlenca, but I would want to pretty carefully monitor their viral load just to ensure that there weren't issues with losing virologic control. Um, I mean, I think essentially if I had a patient who was on Len for ART, this is someone who is probably having a lot of ART specialty requirements. Either it's salvage therapy or adherence is enough of an issue along on a background of resistance that whatever we can do to preserve that is important. And I think that extending that need to preserve Len long-acting treatment through a time of TB treatment would be very reasonable to provide that supplemental dosing.
That makes sense. Thank you. Alice Manos says that was fantastic. Thank you so much. If your patient has been stable on ART prior to TB preventive therapy and you need to make a change in ART, do you usually keep them on the new regimen or switch back?
I think this is again a very patient by patient decision point. I think the principle is that any switch is a point of vulnerability and a risk for loss of adherence or some struggle getting meds. I I will say in the times when I have switched people, the majority of patients have been fine with the regimen that they have switched to, and often prefer to stay on it. And then there are others who say, I really would prefer a one pill if, I was on a one pill regimen before, I want to be back on a one pill regimen, so they go back. I think it's a very shared decision making process.
Great, thank you. And then someone logged on in Madison says, how do you find your patients tolerate the 1 HP regimen? I've heard of incidents of nausea and vomiting is increased, which can lead to understandable non-compliance.
Yeah, so full disclosure, I do not have a ton of experience providing 1 HP because I have had a lot of trouble getting it, and uh, or getting my patients access to rifapentine in the dosing and frequency needed for 1 HP. Um, I think we in the Seattle community have relatively less experience with it. There are some published sort of program evaluations. I know New York City Public Health Department is using a lot of 1 HP. I think where we have the most experience with using 1 HP is in people who really need to complete TB preventive therapy quickly in order to move on to some other forms of treatment. So not necessarily people living with HIV. Um, this is all a little bit of a wandering answer to your question, which is to say that some people have side effects with it. I think daily isoniazid is often a driver of the side effects. So any daily INH regimen is it has a risk of GI side effects in particular. The regimens I have the most experience with are um, just the daily isoniazid for 6 months and then 3 HP, which I am using increasingly. And really, unless there's a strong patient preference or a real insurance issue with being able to get or availability issue with rifapentine, the 3 HP regimen is my go-to. And I know there is data that somewhere around 2% of people will have this flu-like reaction with 3 HP. It's actually less than that with people living with HIV. Interestingly, it was a much bigger issue in the healthy volunteers who were just taking 3 HP. Um, I have not had anyone who is also being treated for HIV have negative side effects with the 3 HP regimen. So I found that to be the best tolerated of the different regimens.
Great. Thank you so much, Adrienne, for a really fantastic talk and slides that many of us will refer to. So thank you so much. Thanks to everyone in the audience for making it today and for those great questions. A brief announcement that we will not have ACC in June due to a change in schedule. So we will regather in July with Dr. Manoj Menon giving an update on malignancy and HIV. So thank you again so much, Adrienne, and have a
Thank
great
you.
day. Bye-bye.